Good afternoon, everybody, and welcome to the webinar. This afternoon, we are in the second part of our In Control series, empowering patients to take control of their heart failure. In today's webinar, we're going to be doing a deep dive into monitoring your heart failure. Before we get started with the meat of the presentation, I just want to remind you that Mended Hearts can be found online at mendedhearts.org, mendedlittlehearts.org, or myheartvisit.org. You can call our Heartline at 1-844-HEART-87, and you can also find us on any of the social media channels. We have really been out there virtually, and we are ready to support you in any way that you would like us to support you. Telephone, social media, online, virtual, video, chat, you name it, we can do it now. A couple of housekeeping rules before we get started to help you out. All attendees are in listen-only mode. If you can't hear me, hopefully you can see the slides. Check the sound on your personal computer to make sure the sound is on. That's usually the problem. If you would type your questions into the Q&A box at any time during the presentation, you don't have to wait till the end. The moderator, which is me, will read your questions during the question and answer period. And then finally, a PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. So today, I am Andrea Baer, your Executive Director of Mended Hearts, and I'm going to moderate the question and answer period. But before I do that, I would like to introduce and turn this presentation over to Dr. Patrick McCann with Prisma Cardiology. He has some great information to share, and so I am going to let him get started. Dr. McCann?
Great, thank you, Andrea. Thank you to all the folks that are joining us today and taking time out of your busy schedules to hopefully learn a little bit more about heart failure. So to give you a little bit of background, I'm the heart failure director at Prisma Cardiology, as well as the director of mechanical circulatory support. So we deal a lot with heart failure from the time of new onset for the diagnosis all the way through patients getting mechanical pumps and heart transplants. So we have a fairly good idea of the challenges that patients with heart failure have, as well as the appropriate treatments in trying to help people not only live longer, but live better with their heart failure. So today I thought I'd go over a little bit with you to talk about current landscape for heart failure, to give you a little bit of background, as well as some of the signs and symptoms that we focus on and discuss with our patients. Tell you a little bit about our clinic and how we approach coordinated care for our patients. In healthcare in general, things have evolved over the last few decades to moving towards more of a team-based approach. And I think heart failure is the epitome of that team-based approach. We deal a lot with other members of the services, such as social work, pharmacy, nurses, advanced practitioner providers, in addition to the physicians. It really does take a village to help people improve and thrive with heart failure. And then lastly, we'll talk a little bit about lifestyle and medications, and then kind of give a summary of everything we go over today. So this is heart failure in the United States. And this is what it looks like in general, except that these numbers are maybe slightly behind. There's actually currently probably about 6 million people in the United States with heart failure. And the challenging part is that we're going to be increasing those numbers in the next decade to about 8 million. And this really becomes not only a matter of health for that patient, but healthcare overall for the nation, with the substantial rise in heart failure hospitalizations. As more heart failure is diagnosed, there's a substantial cost to our medical system, going from anywhere from about 30 billion to about 70 billion by the time 2030 comes around. And so with that, we really need to be aggressively treating heart failure and managing the symptoms so that we can help people stay out of the hospital, help improve their quality of life, but also help reduce the impact overall to our nation. And then you can see here that I highlighted this part, and this is an important part that we discuss with our patients, that about 50% of people are not living after 5 years of a diagnosis of heart failure. And that doesn't matter if it's systolic heart failure, where we have a reduced ejection fraction, or diastolic heart failure, where the ejection fraction is normal, but there's problems with the heart relaxing. Either or, there's not a great prognosis long-term for patients with heart failure. And that's why we emphasize quite a bit to our patients about the importance of adherence to medical therapy, the importance of adherence to a healthy lifestyle, because that certainly can help people live much longer than these 5 years. But it takes a lot of effort and again, teamwork for providing the medical therapy and helping patients be successful. When we look at heart failure in South Carolina, so this is a map of the US, and this is straight from the CDC. This gives us an idea of the overall annual deaths per 100,000, and the darker red is worse, and the lighter kind of pink salmon color is a little bit better. And you can see in South Carolina, we're a little bit of a mix there of both. Certainly not maybe as bad as what it looks like over in Oklahoma or Mississippi, but still some substantial areas where we have a high death rate from heart failure. And I think really what this tells us is, though, although we're not necessarily the worst, we certainly aren't the best either, and there's certainly opportunities for us to make improvements, not only, again, from a mortality standpoint, which is also important, but also a morbidity standpoint, and that means trying to reduce hospitalizations, trying to help people live better with their heart failure, not just live longer. This is another way of looking at some information associated with heart failure. So we just went through all the potential deaths that are associated with heart failure in the US. This is looking at hospital admissions. And if you've ever had heart failure or known somebody that has, a heart failure admission for heart failure is very challenging. One, because there's usually a substantial number of changes to medications. Two, just being in the hospital. It's a pretty sterile environment, especially in the current climate with COVID. It makes it very challenging for seeing loved ones. Obviously, people have to take time out of their lives while their medications are being adjusted. But you can see here with heart failure that it has the large majority of readmissions. And this is why we are so adamant about being aggressive in our clinic and trying to adjust people's therapy and optimize their therapy to help tailor their medical regimen to try and reduce this burden for patients. I mean, you look at it compared to all the other things that we talk about in terms of awareness, right? It's October, it's Breast Cancer Awareness Month, and we have a lot of discussions about breast cancer with women and prostate cancer with men and colorectal cancer. None of these hold a candle to cardiovascular disease and certainly to heart failure in general. And we don't see the awareness campaigns that we wish we would for heart failure. But the reality is that heart failure likely has a shorter lifespan than almost all of those cancers, with the exception of metastatic lung cancer, when we see advanced heart failure. And so, again, just a substantial burden there with hospitalizations for heart failure that we want to try and intervene as best we can to reduce. This is what it's consistently been looking like over the years. Hospitalizations are rising. You can see a 30-day rehospitalization. That means if you're hospitalized for heart failure, there's approximately a 25% chance, that's 1 in 4 patients, that will be readmitted within 30 days. And the unfortunate part about readmissions for heart failure is, again, not only the substantial impact to patients' physical health, but also a substantial impact on their mental health as well, with increasing comorbidity. But also when we see hospitalizations rising like this and multiple hospitalizations a year, mortality rates increase for heart failure. Usually this sort of challenge to keep somebody out of the hospital for heart failure signals that there's a progression in the trajectory that there has been a change certainly in the course of their heart failure, and more aggressive care is necessary. And this is the survival rates that I was mentioning. So when we see somebody admitted with heart failure to the hospital, you can see their median survival with just their first hospitalization is 2.5 years. If you're talking about your fourth hospitalization, you're very likely close to a 50% mortality at 1 year. And oftentimes this is a little overlooked in the medical world because there's a fair amount of discussion around heart failure and other metrics that the hospitals look at. And to some extent, I think there's a little bit of burnout from all these statistics, but the statistics are the numbers, and numbers don't lie. And this is what we see for our heart failure patients. So this is why we emphasize that if patients do have heart failure, that they are referred to us sooner rather than later, because we look at heart failure through a little bit of a different lens than perhaps primary care or even primary cardiology, understanding that the trajectory for a lot of patients is challenging, to say the least. And this is part of the reason why. When we look at heart failure and hospitalizations, this is a graph that shows two areas here at the very end with the red. And so the green is kind of the inevitable hospitalizations, because there are a lot of things that happen outside of a physiologic basis that contribute to people being hospitalized. Sometimes it might not be having the support that they need at home, or challenging socioeconomic conditions. Those things we necessarily can't change with medicine, but we do try with having a pretty robust case management and social work team to offset that. But the red parts here in this graph are things that likely we cannot necessarily change at the end there when it says palliation and priorities. Those are people that are so sick that at some point they will likely die, despite all optimal medications and device therapy, and maybe they're not candidates for mechanical pumps or transplants. Those patients, unfortunately, their heart failure will get worse, and as a result, they will die. Now, a lot of times we work with our palliative care team to try and make that transition as less stressful as possible. If there's a way, there's no way to say that it's a good transition, but if you can at least decrease the stress for the patient and the family, hopefully that has a significant impact for them during that phase of life. Now, the other part here, though, at the beginning where it's the transition phase, this is a part that we spend a lot of time working on, because you can make a substantial difference with medical therapy and good close follow-up for patients with heart failure. And it's important for our patients to have that benefit, because when you're transitioning from the inpatient world in the hospital to the outpatient world, a lot of what was being done is now dependent on the patient. And if they're not provided with the support they need, it's not surprising that they end up back in the hospital. And so we spend a fair amount of time trying to minimize polypharmacy by reducing medications if we can, trying to optimize medical therapy in the hospital, keeping them on what we would consider the appropriate medical therapy at the appropriate doses, but then also providing the support with physical therapy at home and potential for cardiac rehab. And a big part of why we do this is to try and change this course. This is inevitably the course that heart failure progresses through. When I say it progresses, it's a progressive disease in nature. And because of that, we don't have a cure. When I say we, I mean the world. But we do have good medications that can try to flatten that curve a little bit, so there's not such a rapid decline. And hopefully with flattening the curve and getting recovery of the heart function, we can have patients experience a much longer and much better quality of life. But inevitably, there are times when people will decompensate, and that's what this graph shows. Is this clinical course is a downward trajectory with intermittent exacerbations, and those are usually marked by heart failure hospitalizations. We are a little more aggressive, where they are potentially marked by changes in therapy or the escalation of diuretics, because those are small changes, but it signals that something has happened, that those patients are requiring a different approach now than what they were previously. And so they are not maybe as stable as we'd hope. And what we try to do is course correct. It's just like if you were in a plane, the plane doesn't fly straight. There's a lot of bumps and ups and downs, but there's course corrections that are made to try and keep us to that same target, which again, longer and better quality of life. This is just a graph showing the heart failure survival for the time of onset. And I don't say all this to be doom and gloom. I say this primarily to emphasize the importance of having your heart failure consistently evaluated. I think there are times, unfortunately, where heart failure is maybe downplayed a little bit. People have been referred to our clinic and they, oh, I just have a little bit of a weak heart. That's what I was told. It's just a little weak, or it doesn't, not quite as strong as it should be. And they think it's a matter of getting older, and it's not necessarily. It might be a matter of we just need to have you on better medications. But with that, unfortunately, heart failure survival, despite all the advances and changes that we've had over time with good medical therapy, we still have some significant challenges. It looks like we have some questions. Do we want to address those now, or do we want to wait towards the end?
I think that we can wait during the question and answer period to answer the questions, unless it's something that you need to address at this point.
No, we can wait till the end, and I can go over them. I just wanted to make sure that we didn't need to pause. But okay, we'll continue. And I'll drop. But feel free to bring any more questions into the chat, and I'll address all of them as well as I can at the end. Looking at heart failure here, there's a 20% risk associated with heart failure in men and women after the age of 40. And you can see on the graphs to the right that risk increases dramatically as we get older. And the part about that is that our nation is becoming older. It will be not too soon that we're the oldest we've ever been in our nation's history. And with that, we have a higher risk of heart failure. And again, like I mentioned before, as we develop more heart failure, there are likely to be more hospitalizations and an increased burden to the healthcare system. And so doing what we can to try and reduce that is of paramount importance. And this, go ahead and go to the next part. These two circles here just emphasizing that men and women, and especially women after menopause, they have just as much risk for developing cardiovascular disease as men. The increase in population that is primarily driving this heart failure is likely our baby boomer generation, whether it's a reduced ejection fraction or a preserved ejection fraction. Those numbers are going to substantially increase, and that's what you can see here from this graph by the time we get to 2030. And this is part of the reason why, and I mentioned this earlier, 10,000 baby boomers turning 65 today, and that'll happen every day. And this is from a article back in 2011. So we're only about 9 years through this now. We still got about another 10 years to go. This is a generation we need to take care of, and we need to make sure that we're doing our best to optimize their medical therapy should they develop heart failure. So signs and symptoms. We'll probably stay on this slide here for just a little bit. These are the things that we emphasize for our patients. And I like this slide because it kind of gives you, something we're used to: green, yellow, red, right? Just like a stoplight, maybe in reverse order there. But the green are the things when they're going well. And when patients have heart failure and they're not having any worsening shortness of breath, they can complete all the activities that they normally would. Their weights are stable. Those are all signs that tell us, hey, your heart failure is in check. It's being well treated with your medications. Now, when we come down to the next one of the yellow, this is probably the time where people need to be either calling or contacted by their provider. And when you start having a cough, or if you notice that, usually I go for a 20-minute walk with the dog there, and now I'm having to stop at 10 minutes because I'm a little short of breath. That's not something to overlook, and we discuss this with our patients routinely. If you can stay with a routine physical exercise on a daily basis, whether that's 15, 20 minutes of walking, whatever it might be, if you can do that consistently, that helps providers understand that if there is a change there, that might be related to your heart potentially if you can't walk as far or you get more short of breath with it, as well as increased swelling and weight gain. And it's not necessarily always in the legs, feet, and ankle. Sometimes, quite often, we'll have patients that have abdominal distension because they get swelling in their belly. So if pants start fitting tighter, or people aren't eating as much, or don't feel hungry, or get full really quick after eating a small amount, those are concerning signs that a provider should address. Certainly weight gain, 2 to 3 pounds in a 24-hour period or 5 pounds in a week, also something that needs to be addressed. The trouble sleeping, sometimes it's a little bit of restlessness, but other times it's because you wake up short of breath or you get short of breath with laying flat. If that happens at any time, not only do you need to contact the provider, you probably need to be seen by the provider. Difficulty sleeping is a pretty sensitive sign for worsening heart failure. Now, the times that you maybe need to get to the ER are listed in red. The frequent coughing, probably not so much. It can still be contacting the provider. But if you're getting short of breath at rest, if you're having difficulty completing sentences and communicating to people because you have to take a breath, that's emergent. You need to get either into the clinic or to the ER. And a lot of times with our clinic, we will try to get people into the clinic without having to go to the emergency department, just because we know there's better continuity of care that way. But those sort of things shouldn't be waited on. Same way that if you start having pain with the abdominal swelling, or if you've gained weight and it hasn't gone back down, if you gained those 2 to 3 pounds in a 24-hour period and you called your provider and they maybe made some adjustment to some medications, but then you continue to gain weight, again, either into the clinic or to the hospital. If you're starting to have any evidence of confusion, and this can come along sometimes with change in mood because the brain's just not getting enough supply of blood from the heart. Loss of appetite is another important topic that we talk about. Towards the worsening stages of heart failure, people start to have what's called cardiac cachexia, and that's a state of malnourishment with high inflammation, and they begin to look similar to if you've ever seen somebody with advanced cancer, because their body is just using up so much of the resources and they don't eat very much. They start to have thinning of the temples. Those are very late signs of heart failure and should be seen immediately. And certainly, again, if you can't lay flat, that's not something that we want to wait around for to see if that will get better. That's a problem that needs to be addressed immediately. This is sort of what conventional care looks like in general for a lot of places, and certainly for a lot of heart failure patients. And this is a vicious cycle, as it says up top, where patients are seen in the office. They have heart failure symptoms that can't be met by what the clinic can offer potentially, and then they end up in the emergency department for some of those parts in red that we just spoke about. They end up going into the hospital. A little bit of fluid is taken off, and you can see there in that pie, if you go to the hospital with chest pain or shortness of breath nowadays, chances of being admitted are pretty high. You go into the hospital, you get a little bit of treatment, and then you come back out into the clinic, go to the physician's office, but potentially maybe some of the medications were changed, or maybe the medications weren't sent, or the heart failure is getting worse. The challenge here with healthcare nowadays is it's a little fragmented. I shouldn't say a little, it's a lot fragmented. It used to be that your physician took care of you in the clinic and then took care of you in the hospital and then back to the clinic, and there was a fair amount of continuity there. And unfortunately, that's just not how our healthcare workforce is set up. And part of that is because of the explosion of knowledge for medicine in the last 30, 40 years. The other part of it is the realization that hospitals are open 24/7, and shifts are needed for that. You can't necessarily keep workers in a hospital 24/7, but that becomes very challenging for the patients that are pretty ill, and especially with heart failure, need routine follow-up. So one of the big parts that we try to do to alleviate this is change our approach to the conventional method, and we'll show you that here in the next slide. So up top, you can see a traditional clinic where there's a large arrow going from home to the ED. In the bottom, what we try to do is reduce the amount of patients going from home to the emergency department. And we do it through a number of interventions. And a big part of it is the multidisciplinary approach. And that's what I mentioned earlier in the talk, is the importance of teamwork. So we have pharmacists in our clinic that are dedicated to helping patients with medications. We have social work support to try and help our patients should they have any other needs outside of the physiologic needs from heart failure. We work with our palliative care team in advanced care planning as well, so that we have discussions about end of life if somebody's heart failure is so severe without many options. We also have the ability to do infusions in the clinic. So the same sort of medication people would be getting in the hospital, we can provide in the clinic. They might have to stay for hours in the clinic, but that might be better than a few days in the hospital. We do a lot of work with education and titrating therapy and trying to optimize medical therapy. So there's quite a bit of clinic visits, but it is with the goal to stabilize patients, optimize their treatment, and again, improve their life overall. The other part here on the left that you can see is remote monitoring. We have the capability now with our pulmonary artery sensors to actually implant these and see what patients' filling pressures in their heart are from home. People lie on a little pillow. It takes about 20 seconds to transmit, and we monitor those pressures on a daily basis so that the patient actually has the heart failure team watching them regularly, and we can call with changes that we need to make for medications. It's a way that we are able to provide more proactive care instead of reactive. And all of this is focused, again, around trying to reduce patients ending up in the emergency department of the hospital, which we know, again, has substantial impact on morbidity and mortality. So when I talk about multidisciplinary care, here's all the people that it takes to try and do things well. And we mentioned a lot of the providers in the last slide, but the other part that I like to point out here is cardiac rehab. All right, so we all come with unique training backgrounds, and the important part of every member of the team is to try and make things better, and we wouldn't be able to do that without cardiac rehab. And this is a part that we emphasize to our patients. We probably send at least 85% of our patients through cardiac rehab at one point or another. And the idea is that it's routine exercise. And everybody says, oh, well, I can maybe do that at home. And maybe you could, but there is quite a bit of other things that the routine exercise addresses. It addresses, well, how are your vitals doing when you're exercising? Because not everybody has the ability to do that at home. It also provides more support. It is a routine where people actually have to get out of their house and go somewhere and engage with other people routinely. And with that, mental health improves because you realize that there are other people there that are in the same boat as you are, just like the rest of us. We're all sort of in the same boat to an extent. But sometimes we forget that a little bit. And so the cardiac rehab has so many benefits for patients. And I want to make sure we highlighted that in our approach to multidisciplinary care. Next slide. And so our program at Richland, I mentioned that part of the clinic, but that's only one piece to it. And really what our program seeks to do for all of our patients is help coordinate the care for their heart failure, not only through their inpatient stays, but also through their outpatient. And we do that with a significant emphasis on transition of care. When patients are discharged from the hospital with heart failure, that we're helping care for, they have an appointment within 1 week of discharge, so that we make sure that that transition of care is going as smooth as possible. And then we again, course correct if we need to, and again, aggressively adjust medications to try and help prevent any sort of relapse of heart failure. The remote monitoring has been a big piece of our program now for probably about the last 5 years since the device was available, the CardioMEMS device. But we also work with our partners in telehealth, as well as any patients that have had ICDs placed. Some of the newer models for ICDs, if you're not familiar, that's an implantable cardio defibrillator. It's similar to pacemakers, but the newer models have algorithms that allow us to more closely monitor patients' heart failure symptoms. And they've been substantially beneficial in some of the trials. And we've been utilizing those probably for about the last year and a half now with excellent success. This is a little graphic out of Journal of American College of Cardiology. And the important part of this graphic that I wanted to put on here is this trajectory check. I think that cannot be emphasized enough that in heart failure, it's a lot of adjustments, but then we check where we're going. Similar to the analogy of the flight, right? We course correct, but we make sure we're staying on target. And when we're not staying on target, then we course correct again. And it might be that maybe we need to change medical therapy. It might need to be that we consider device therapy or maybe even cardiac transplant. It just depends on each patient, and each individual patient is unique in what they will need for medication, and they are unique in what they need for the appropriate approach. But with our trajectory check, that every time we do this is what our focus is when we're seeing our patients. We see the problem, we address it, and then we see how the problem is going afterwards. And when they do well, which most of our patients do, we move into the optimization phase, and then they're discharged, and then we transition to chronic care, and again, continue to do those trajectory checks intermittently as we see patients in the outpatient clinic. And this is just another way of looking at that, saying, hey, if you're improving towards target, great. We continue to towards decongestion with water pills, but then we also optimize the GDMT. And that's the important part there for heart failure therapy at home, is optimizing the medical care. It's not just a matter of getting you on what we know is good medical care. It's trying to get patients to optimal medical care. And optimal is different for every person. What works for me may not work for the next person, may not work for the person after that in terms of medical therapy. And so we try to take a very personal approach in tailoring the medications. We are not at the point in science where we can draw blood, check genetics, and understand which medication will be best. But we are at a point in science where we know there are certain classes of medications that will have much more benefit for patients in regards to their heart failure. And even most recently, there were some medications that were initially developed for diabetes, which have shown to be actually much more beneficial for heart failure. And so it gives us another tool in the toolkit, and we have quite a few of them, but we make these adjustments, again, to try and optimize that medical therapy, to try and have the minimal amount with the most impact. The other part that we emphasize is self-care, right? So this, I mentioned previously that if you're over the age of 40, you got about a 20% risk of developing heart failure in your lifetime. Doing these 5 things, well, yeah, one of these lifestyle factors over here, so there's 6 of them there that are listed, but doing 4 out of those 6 substantially reduces your risk of developing heart failure. In addition, people that have heart failure, doing these same things substantially reduces your risk of worsening progression. And so with that, we see that, you can go from that 20% risk down to a 10% risk, and it's not really asking a whole lot. Trying to not smoke, trying to maintain a healthy body weight, trying to exercise, limiting your alcohol intake, even breakfast consumption, right? So a lot of people always ask me about that, and they say, well, really? Just eating a bowl of cereal? It's not so much just eating a bowl of cereal. What it is that if you consistently are eating that breakfast cereal, or maybe a different type of breakfast, you likely have a routine that you keep. You are likely the person who's limiting your alcohol intake and exercising routinely and eating fruits and vegetables because you maintain that routine. And that is a big part for anybody with heart failure of longevity, is maintaining a good diet and exercise routine. So current therapy, oh, so many current therapies, so many drugs. The class 1 here are things that should be utilized for medications for patients. And so that first part there where it says ACE, ARB, or ARNI, a lot of you might be familiar with some of these medications or heard about them. The ACE inhibitors are things that end in prils, like lisinopril or ramipril or quinapril. Those are all very good medications for heart failure. Similarly, ARBs are things that end in artins, like valsartan, candesartan, losartan, all very good medications as well. And then the ARNI, the ARNI, the only one of those is Entresto currently on the market. It's a very good medical therapy, and they are all recommended by the American College of Cardiology, American Heart Association, and the Heart Failure Society of America to be utilized to try and help reduce morbidity and mortality for heart failure. Beta blockers are similar in terms of their reduction in mortality and morbidity, and you probably know some of these medications such as metoprolol or carvedilol, all very good medications. Aldosterone antagonists, the same way. Medications like spironolactone or eplerenone are aldosterone antagonists that can be very good for patients with heart failure. Vasodilators, medicines like hydralazine and Imdur or isosorbide, those are medications that also have substantial beneficial effects, especially in the African American population. And then lastly, I put on here, it doesn't have a class 1 indication just yet, but likely will. And these are what's called SGLT2 inhibitors. And without getting into too much of the pharmacology, these are medications such as Farxiga or Jardiance, very good medications overall for heart failure. In fact, they were, again, initially developed for diabetes, but the evolution of their utilization is likely they are heart failure medications that help blood sugar as opposed to diabetic drugs that help heart failure. The class 2A here, these are medications that you could consider using, and ivabradine, or by its brand name is called Corlinor, is another medication that could be beneficial here for patients with heart failure. And then vericiguat is a medication that was just looked at in terms of helping hearts contract better. Certainly has had beneficial effects for reducing hospitalizations. Unclear about mortality benefit at this point, but it certainly could be used as an adjunct to therapy for patients with heart failure. The point of all this isn't so that you remember all of those medications. Maybe you'll be a little more familiar with them now, but the point is to say that we have a lot of tools now. There's never a good time to have heart failure, but if you have heart failure, this is a better time than where we were 30, 35 years ago when we had none of these therapies available, and what we did have available didn't really help people live longer necessarily. And so now we have quite a few options when it comes to medical therapy that if somebody doesn't tolerate medications for a particular reason, we can use another one. And generally we will have people on at least 2 to 3 medications for their heart failure, because we know that if we're aggressive about it, again, we have a good chance at getting recovery, but we also have a good chance at delaying that person's progression for their heart failure. Unfortunately, we have a lot of work to do, though, with all these medications. And I put this slide up here because a lot of people say, well, how is it that we have all these medications, we've had all these trials, we show the benefit, and yet we still have such a significant mortality rate with patients that have heart failure? And certainly this is part of the contribution to it. And what you can see here is these are those classes of medications I was just telling you. These are all medications that have a class 1 recommendation: the ACE, the ARB, the ARNI, the beta blocker, and the MRA is the aldosterone antagonist. And what you can see in the orange there is that these are patients that they don't have a contraindication to it. They have no reason why they shouldn't be on it, but they're not being treated. And they're substantial, right? I mean, when you look at the aldosterone antagonist, almost 70% of patients aren't being treated as they should. And this was data that was drawn from Medicare about in 2018, trying to get a real world sense of the treatment that patients are receiving for their heart failure. The other part here is that the patients that are being treated is just in the green. And we can see that we do a decent job with the ACE-ARB, ARNI combinations and the beta blocker. It's not bad. We're almost hitting 70%, but boy, I think we could be doing better. And then you can see the patients at the very bottom, there's that sliver of yellow, tiny little bit of yellow. And those are patients that have contraindications. And so I think what we take away from this certainly is two things. One, we need to be more aggressive about medical therapy, but two, there are a lot of patients that could have substantial benefit, and maybe we could make an impact on some of those mortality curves if we really pushed aggressive medical therapy that, again, likely patients would be able to tolerate, as you can see the very small numbers of people that have contraindication there at the bottom. Next slide. This is the other thing that I think likely contributes. It's not just the challenge with getting people on good medical therapy, it's also how do we check up on them and keep them on it. And so the majority of people I don't see on a routine basis. We see them in the clinic, and even if we saw somebody monthly in the clinic, they're still 29 to 30 days out of that month we don't see them. And this is really what this graph tells you here, is that the majority of the time people are at home. They're not in the heart failure clinic, they're not in the device clinic, they're not in the hospital. But the times they are, you know, certainly in the clinic, we may be able to impact them, but what if we could do some things at home? And that's really what this gets to, is maybe we need to increase the access to care. And perhaps that is part of the reason why maybe some of the patients that we saw on that last graph aren't getting as much medical therapy as they should be. Next slide. So one of the ways we do this is with CardioMEMS, and this is that little tiny device there above the dime, or behind the dime rather, is what's called a CardioMEMS device. And it's an implantable monitor. Inside the casing is a manometer, and it checks pressures through a blood vessel in a pulmonary vein that's close to the heart. And that's actually the real size of it. It's a tiny little thing. It takes about 30 or 35 minutes to implant. But by giving us the information for the pressures which are reflective of the pressures inside the heart, we can be very proactive in managing patients' heart failure while they're at home. And once we optimize patients after the implant of this device, they can transmit their pressures 2 to 3 times a week, and we can still maintain very good access to care there. And again, this is primarily utilized to reduce hospitalizations, and we've had very good success. We have about a 70% reduction in hospitalizations from 1 year pre-implant to 1 year post-implant for the patients that get this device. So not only do we have the reduction in hospitalizations at 70%, but we run close to a 70% reduction in emergency department visits for those patients as well. So you can imagine if somebody's not going into the ER or not being into the hospital nearly as frequently as they were, their quality of life is probably substantially improved. And in addition, they're getting our heart failure team looking at them routinely, as opposed to that tiny little sliver that we saw last slide. Next slide. There we go. And this is how it works overall for those that aren't familiar. And you may not be as familiar with it. You may have heard of somebody that does have it, but what you may not realize is that Prisma at Richland, we are one of the largest centers in the world. Actually, I think we're probably top 2 or 3, certainly in the nation. But we have a lot of experience with this device, and we have a lot of great outcomes for patients and helping them stay out of the hospital. But this is basically how it works. We do the implant, and then the patient lays down on their pillow there and transmits the device. It takes about 20 seconds or so, and then we see the reading, we review those readings, and then we call the patient for any changes that we need to make for their medical therapy. And sometimes we don't need to make any changes. Sometimes their pressures are stable and they're right where they need to be, and then we don't have to worry about any of that. But sometimes we do need to change it, and if we do, hopefully augmenting their therapy will help prevent them from being in the hospital. Next slide. And this is just a couple examples I like to show of what we're able to do. And this was a patient that you can see that sort of green line there, and that's one of the things that we go by. And when he had the big dip there in the middle, that's around March of 2018, what happened is he unfortunately had an ulcer and he had some bleeding, and you can see that his pressures all went down, and that was likely secondary to some of the blood loss he had. This happened at a hospital inpatient stay that wasn't affiliated for heart failure, but it was for bleeding. But all his medications were stopped. And you can see how his pressures went up dramatically. And then we got him back on good medications after he had some significant challenges with his bleeding and his ulcer. But you can see how he was off his medication, his pressures went back up. And then around that September timeframe is when we started getting him back on good medical therapy. And you can see how his pressures came down nicely. And he did much better. And again, he remained out of the hospital following his discharge from the ulcer, where we were able to improve his filling pressures with medical therapy. And he's continued to do well since, hasn't been readmitted to the hospital, which is great for him overall. Next slide. This is another patient with a much less dramatic change there. But you can see initially over there in December of 2018, our pressures were a little bit higher there. You can see probably by about that sort of around there February, she'd started decreasing. She had a couple little bumps, but overall, the green line that we're looking at there is getting close to that 20 number. And you can see underneath, that's kind of a little bit of a better graphical representation in the gray there of how her pressures have decreased. And this is all being done while the patient's at home, not necessarily coming into the clinic on a weekly basis or on twice weekly basis. We're watching her pressures from home, and we're adjusting the medications to course correct, and she's ending up with lower pressures and feeling better overall. So in summary, it takes a village. Heart failure is challenging. I wouldn't wish it upon anybody. It is a challenging diagnosis to treat, let alone to live with. But regardless, with all the cardiovascular disease and other comorbidities, especially with the rise in diabetes and hypertension, inevitably heart failure will continue to develop. And as like I mentioned, over the next 10 years, there's probably going to be about an additional 2 million patients. So we are working towards maintaining this team approach, and this is what you see here. It's really takes a village to help patients with heart failure, because there are just so many different facets to somebody's diagnosis, whether it's the person that might be at the end of their life that needs palliative care and hospice, which we help them with medications that can help them feel better during that time, or the person that's newly diagnosed and doesn't know what to make of all the medications, or maybe it's the person that just needs some help with education or case management and some socioeconomic challenges. But it really takes quite a bit more nowadays than just one person. It takes a team, and that's what we've built here at Prisma to help our heart failure patients. So with that, we'll take any questions here. I'll try and address everything as well as I can.
Thank you so much. That was really interesting. I just want to remind everyone that you can type your question into the Q&A section of the little white box that you have. It should say Q&A. You can type your question there and we will get to them. The first question I have for you is having AFib considered having heart failure? If not, how is heart failure defined?
That's a good question. AFib is not the same as heart failure. AFib is more of an arrhythmia issue. Now, interestingly though, about 40 to 45% of patients with heart failure will have atrial fibrillation. So they're closely connected, but very different, distinct entities. The challenging part when people develop heart failure with atrial fibrillation, it's a little bit of the chicken or the egg. Certainly, if people have atrial fibrillation and their heart rate's been going very fast for a period of time probably on the course of multiple weeks to months, they can develop heart failure. But the same is true in the reverse aspect. If somebody has heart failure, they have remodeling of their heart, and over time, they're more prone to develop atrial fibrillation. So distinct entities, but fairly frequently related.
Great, thank you. So as far as hospitalization due to heart failure, are there any newer statistics since 2004? And is it going up or down?
No, it's unfortunately they've been stable since about that time. There really haven't been substantial benefits to the mortality. There's been maybe a slight decline in hospitalizations, but the mortality remains the same, unfortunately. Even in some of the most recent epidemiologic data from 2016, we haven't made substantial impacts in mortality, and that's been looked at a few different registries, not only from the States, but also the UK as well, because they have a pretty robust data resource over there with having the National Health Service.
Great, thank you. So the next question is, I had double bypass surgery in July of 2019. As a professional singer, how do I get my breath control back?
Whoa, that's a tough one. It's hard to know because it depends on what occurred during said bypass surgery. I would say as a professional singer, a couple things that would be best probably in terms of getting your breath control back. One, and you can ask your provider about an incentive spirometer. Those are the little things that you blow into, suck air out of to try and get a rise in the bellow. And the part to that is that it helps expand the lungs while you are resting. So a lot of times our lungs will expand and open up more as we are moving, but when we are potentially sedentary and after bypass surgeries, especially some substantial recovery times, the lungs need to kind of be reminded to open up more. And so sometimes the best thing is a little bit of incentive spirometer. And then if you've completed physical therapy already at home, or if you're going through that, the next step would be, as I mentioned previously, the cardiac rehab to really try and push the recovery and conditioning. And as you do more of that, again, the lungs are required to open up more, and that will probably help with the breathing.
Great. So the next question, actually it's a couple of questions, I'll combine them, has to do with hospitalizations. The first piece is, how do insurance rules and regulations play into hospitalizations that are necessary due to heart failure? And then, are some patients discharged too soon due to insurance, or is it because they're insisting on leaving the hospital? What are the reasons that they're discharged so quickly?
Sure. So the first part of it, as far as insurance goes, it's different with every insurance. Unfortunately, insurance for a large part is the bane of our existence in treating patients more and more, because the bureaucracies sometimes can be very challenging to navigate. But the part of the reimbursement really is dependent from insurer to insurer. But certainly the vast majority will pay for a heart failure exacerbation where somebody has to be in the hospital. The second part of moving patients out of the hospital quickly probably has to do more with hospital administration, as opposed to, and then also loosely connected with insurers, because there's a certain amount of payment based on diagnosis. And with that, if patients are spending significant amounts of time in the hospital, then a fair amount of the care ends up being provided pro bono by the hospital. And unfortunately, that's not a good way for doors to remain open. And that's the reality of it overall. And so there is a little bit of I wouldn't say push, but certainly nudging at times to say, okay, does the patient need to really be here? And still after they're initially treated. But regardless with that, our experience at Prisma certainly has never been reducing the amount of care somebody should be getting before they leave the hospital. That's not the case. By all means, we have a very good relationship with our administration, and they have an understanding that, you know, when we say that something is necessary for the medical care, it's necessary, and if that takes some extra time, that's just what it is, and they'll have to do the arguing with the insurance company on the back end.
Great. Great. So a couple of questions about the cardio MEMS. One is, do you have to have an outside agency monitor the patients with the cardio MEMS, or do you guys have that built into your program? Is there a specialized home health agency that needs to come or be a part of it? And the second part of that is, can the cardio MEMS be implanted if the patient already has an ICD device?
Sure. So the second part first, absolutely. If somebody has an ICD, we can certainly implant a cardio MEMS. It has no interference. It's MRI compatible. It's CT compatible. It's chest X-ray compatible. It's a very easy device to implant. It doesn't interfere with an ICD or a pacemaker. The first part of it, of that question, we do not have an extra service to come and help. We actually have that all set up in-house already with our nurses and APPs, our nurse practitioners and our PAs for the help to take care of those patients. So the only thing we do utilize as an outside service is the computer interface. So that is set up through Abbott, who is the provider for CardioMEMS. They manufacture the CardioMEMS. They also have put together the software where we can interface to see the data, make the appropriate changes, do all the trends, everything that we do on our end as far as helping take care of patients. So there doesn't need to be a home health service that comes in. We do the training with patients following implant. It's very simple to set up at home. If you've got a cell phone connection or a Wi-Fi connection, it can work both ways. So it really increases access for people across the board, but no additional services are needed in the home, just the pillow that comes with the device and the little monitor. That way people know it's connected and sent the information. And it takes, again, maybe half a minute or so to do a day.
Great. Okay, we are getting up to the end of the hour, and I want to be respectful of your time, so I'm just going to ask a couple of other questions. One, I wanted to let you all know that the next webinar in our series, which is next Thursday, will be a real deep dive into the heart failure monitoring system with the cardiac MEMS and a couple of others. So if you have, I see there's some questions here about criteria with cardiac MEMS and a lot of those questions. We will be able to answer those next Thursday, if you can check back if we don't get to you today. So my couple of last questions. If one has high blood pressure, does that automatically mean the pressures inside the heart will be high?
It depends. Depends on how high the blood pressure is and whether or not that's affecting the heart. For people that have chronic hypertension, probably with systolic blood pressure that can reach in the 170s and 180s, it most likely does have an acute effect on the heart. Long term, even blood pressures in the 140s or high 130s long term will have an effect on the heart. That's why the current recommendation is to have blood pressures less than 130/80.
And I think final question, I'm sorry to everybody who we didn't reach your questions. We do have them cataloged and we will try to get to answers for you. Is it possible to have a diagnosis of heart failure, then have ejection fraction improvement and no longer have heart failure?
Yeah, that's an excellent question. No, that's not the case. Once you have heart failure, you have heart failure. Now, with that, if you get improvement in the ejection fraction, that's excellent. Well, we know that when people recover their ejection fraction, is they have similar long-term prognosis to their age-matched cohorts. However, the point I like to make for all of our patients is once we have people on medical therapy, if they have improvement in their ejection fractions, we recommend people to stay on medical therapy. What we know from other studies is that if people stop their medical therapy for their heart failure, they have a higher risk of redeveloping heart failure. And if that happens again, they have a lower chance of recovery of their ejection fraction the second time around. And with that, that certainly impacts long-term prognosis.
Great. Thank you so much. So we have come to the top of our hour. I know that there were a lot of other really great questions, and I'm sorry we didn't have time to answer them. I just wanted to invite you to next week, Thursday at 3 o'clock, same time, same place. We'll be back with our third installment, which will be taking a deep dive into the monitoring of heart failure with the cardiac MEMS system. And I also wanted to gratefully acknowledge an educational grant from Abbott that has made this series possible. Dr. McCann, thank you so much for joining us today. It has been a wonderful hour of learning for us. And everyone who has joined us, thank you for taking your time out of your day to be here with us. We hope to see you back here next Thursday. Thank you all and have a great day.
Sure. Thank you. Y'all have a great day.